Hi, my name's Olivia. I'm a fourth year pharmacy student, and I'm going to be talking about pneumonia today. So to start, we're going to define some things. We've got CAP, HAP, and VAP. CAP, community-acquired pneumonia. It develops outside the hospital. Symptoms appear before or within 48 hours of admission. HAP, hospital-acquired pneumonia, develops in the hospital. Symptoms appear after 48 hours of admission. And then we've got VAP. Ventilator-acquired pneumonia, develops within 48 hours of intubation and up to 48 hours after extubation. So what is pneumonia? It's an infection of the lungs caused by bacteria, viruses, or fungi. The infection causes the lungs' air sacs, the alveoli, to become inflamed and fill up with fluid or pus. This makes it difficult for oxygen to get into the bloodstream. It is the leading cause of hospitalization in both children and adults. Tens of thousands of people die from it each year, most being over 65. Symptoms include coughing with or without mucus, fever, chills, shortness of breath, chest pain, nausea, vomiting, and diarrhea. Some risk factors include being 65 and older, chronic conditions like chronic lung diseases like COPD, bronchiectasis, cystic fibrosis, chronic illnesses like heart disease, diabetes, sickle cell disease, being immune compromised, having HIV or AIDS, having an organ transplant, or being on chemotherapy or long-term steroid use. If they've had a recent viral respiratory infection or hospitalization, that also increases the risk of having pneumonia. If they smoke, do drugs, or alcohol abuse. And then environmental factors such as exposure to chemicals, pollutants, or toxic fumes, including secondhand smoke. So CAP, the bugs we want to worry about are Streptococcus pneumoniae, H. flu, and atypicals. Some things we're going to be thinking about while different differentials on other diseases that could be at play instead of pneumonia would be chronic lung disease, pulmonary edema, or pulmonary embolism. So things to do to figure out which one it is would be a CT scan and a chest x-ray. And then duration of treatment for CAP is 5 to 7 days. For outpatient, we will treat based on their comorbidities. So if they don't have any comorbidities, we can use amoxicillin or doxy or a macrolide, such as azithromycin, depending on the resistances in the area. And then if they have one of these comorbidities, chronic lung disease, chronic liver, chronic heart disease or renal disease, diabetes, alcoholism, malignancy, or asplenia, then we need to cover for more bugs. So we're going to be using a beta-lactam and azithromycin, or we can use a respiratory fluoroquinolone like levofloxacin. And then if we're inpatient, we treat based on severity. So severe pneumonia would be one major criteria or 3+ minor criteria listed here. If it's non-severe, we can use a beta-lactam and azithromycin or respiratory fluoroquinolone. And then for severe, we would use a beta-lactam and azithromycin, or we could use beta-lactam and respiratory fluoroquinolone. So these are the different medications for inpatient and outpatient, because there's different meds, inpatient, outpatient. So outpatient beta-lactams we would be using would be amoxicillin, clavulanic acid, cephalexin, ceftonir, or cefodoxime. And then inpatient would be cefotaxime, ceftriaxone, and ceftaroline. And then when we're thinking about when to admit to the hospital, we have two different guidelines we can use. We've got the PSI, the Pneumonia Severity Index, as well as the CURB-65. So the 2019 IDSA guidelines recommended use of PSI over CURB-65 for determining need for hospitalization. But there is more literature to support PSI in accurately predicting mortality. However, the PSI incorporates data that may not be available in all circumstances, especially to an outpatient physician. I didn't list them here because there was so many, but there are things included like pH and a lot of lab values you'd only have inpatient or like in a ED situation, not like an urgent care. PSI is more helpful in emergency department and CURB-65 more efficacious for outpatient setting. So it just kind of depends on where you're being treated that you would use each one. So PSI, they have different risks, and then tells you based on their score whether you should treat them inpatient or outpatient, as the same kind of thing with CURB 65. So it's like the CURB 65 is estimating the 30-day risk of mortality. So if you don't get them in the hospital, they're going to die in a month, basically. So it gives you a guide on whether to treat them inpatient or outpatient. And then HAP and VAP, we treat slightly differently because we're more worried about different bugs. There is a higher risk of Staph aureus, Enterobacteriaceae, and Pseudomonas, and we treat for 7 days. So the drugs, if the gram resistance is over 10%, or if they have structural lung disease, then we're going to do dual anti-pseudomonal therapy. If not, just single anti-pseudomonal monotherapy. And then if they've got a severe beta-lactam allergy, there's some options. And then also if they've had IV antibiotics in the past 50 days, or if they have high risk of mortality, or if the MRSA prevalence is high in the area, we were going to add coverage for Vanco. Add coverage for MRSA, so usually Vanco or linezolid. And then these are the anti-pseudomonal beta-lactams. So we've got piptazo, cefepime, ceftazidime, meropenem, and imipenem. And yeah, that is everything. If there's any questions, please leave me a comment. Thank you.